So just a little bit of housekeeping that I wanted to go over with everyone. This meeting is being recorded. I wanted to let you know, because of the large size of this webinar today, we brought everybody into the webinar muted, and we are going to keep folks muted for some parts of this webinar, and then we'll have some opportunities to unmute and ask questions. But in the meantime, I absolutely welcome you to share in the chat throughout. So if you've got a question, if you've got a comment, if you've got a counterpoint to something someone is saying, whatever it might be, please feel free to be really active in the chat throughout the webinar. We definitely, want to welcome that engagement and feedback. Following the presentation today, everyone who registered and attended will get a copy of the presentation and a link to the recording. You will also get any additional resources. Sometimes our presenters, as they get going, think of additional things that maybe they hadn't put in their presentation to start with. And so I will make sure that you get copies of all of those, as well as your attendance CEU certificate. But I actually just work a few hours a week for the department. And also it takes us a little time to kind of pull everything together. So if you can give me up to about 2 weeks to get those materials by email, I would appreciate that. And also, my email is on the bottom here. If you are joining from in a shared computer, so if a couple of you from your, oh, you know what, that seems silly to say today. I was gonna say, if a couple of you from your office are all joining together, that does not seem super likely. But if that is the case, if a couple people are joining from a shared space, if you could send me an email individually and let me know that you participated, that would be great. Also, we are not using video for this meeting. So if you, for some reason, had your video toggled on, if you want to just turn it off now, that would be great.
Hey,
also, if it looks like maybe 1 or 2 folks are having some trouble with their audio. And so if you're having any trouble, just share that with us in the chat and we'll help you address that on the back end. I know that we've got a lot of folks on today. So that was my little spiel about kind of getting things going here at the beginning. And so if we can skip to the next slide, I would love to introduce you to our presenters. So lots of you know Pat McGovern. He's the Suicide Prevention Director at the Iowa Department of Public Health. He's a data manager in the Bureau of Substance Abuse, and he's the director of the Iowa Youth Survey. He's been with IDPH for about 7 years, working on suicide prevention his entire time there. Pat values feedback from all and believes in the importance of engaging those with lived experience. He was a program evaluator prior to his time at IDPH, and he feels that the critical thinking skills and data familiarity that he developed then has enhanced his opportunities at IDPH. He enjoys spending time with his kids in whatever adventures they can find, and is a certified soccer referee, often spending his Saturdays refereeing kids' games. So welcome, Pat. We also have Lori Reynolds, LISW. She's been a provider for mental health services since graduating with an MSW from the University of Iowa in 1993. She was independently licensed in 1995. For the first 14 years of her career, she worked in community mental health as a psychotherapist, first with children and adolescents before changing to strictly adult care in 2003. Lori has been employed by VA Central Iowa Healthcare System since August of 2007. She originally provided social work services in an acute inpatient psychiatric setting, and she moved to providing outpatient psychotherapy in 2013. Currently, she holds a position of outreach and education specialist for suicide prevention, which is soon going to be changing to community engagement and partnership coordinator. Vision 23 Leadership created this position because every day we lose 20 veterans service members to suicide. And of the 20, only 6 are involved in VA care. And so the VA is taking a public health approach to suicide prevention in an effort to reduce not only suicide in veterans, but non-veterans as well. In addition to traditional outreach in our communities, the people in the role are also working closely with their communities to build or enhance coalitions with the vision of preventing suicides. So I am really excited to have such experienced folks that are have background in this and are doing the work in this area and are really thinking about not only how to share the information, but how to connect people around the information. Where I also think this really is an intersection with what we're doing in prevention. And so I'm going to now kind of virtually hand this over to Pat, who's going to get us started.
Thank you, Claire. Can you hear me okay before I go any further?
We sure can. I can.
Excellent. Excellent. Thank you, everyone, for being with us today. We have a lot of wonderful information to share with you. Hopefully, you find it beneficial. Um, we know that there's a lot of uncertainty in our world right now that none of us could even anticipate a month or two ago. And so things are changing rapidly, and that brings a lot of additional risk, especially as it relates to suicide. So please do ask questions and things like that as we go through. Lori, would you advance to the next slide, please?
And hey, Pat, I apologize that while she's doing that, I also had made myself a note to remember to say to folks, just given the different kind of landscape and the way that folks are managing work right now, that we absolutely understand that you may be working in a different space with not maybe your internet isn't as reliable, maybe your dog is barking in the background, your kids are climbing on your lap, whatever it might be. And we just want you to know that we absolutely understand and want to just be really supportive of folks and appreciative that everyone's able to get on and connect and share this information. So please know that this is a very hopefully low stress to participating, and not to be concerned if any of that's happening on your end.
Absolutely. Thank you, Claire. I say simple rules here, 3 simple rules. I don't know how simple they really are, but really just want to always acknowledge the importance of self-care, that we are in the helping profession, whatever your role is. But if you're not grounded, if you're not in a good place, it's going to be a lot harder for you to help others get to their safe place and their grounded place. So please do what you need to do. Say move as you need to. You're like, well, how do you move on a webinar? If you need to move away from this webinar for a bit, if you need to kind of mute us and take your headset off and go read an inspirational note, or go for a walk around your house, or inside or outside, do that. That suicide is a topic that is sensitive, and it's not easy, and it does bring out things, brings up things like, what, I thought I was through that. I thought I was done with that. That was a long time ago, but it can still come up and just hit you when you least expect it. So move as you need to. As we're doing this webinar today, and as you're thinking about suicide prevention, what you can do to help others and to keep yourself grounded. And ask your question. Ask your questions now. Ask your questions when you're worried about someone else. Research shows, talking to people with lived experience, it's okay to ask someone, are you thinking about killing yourself? Are you feeling suicidal? That if we tap dance around that, you're not thinking about hurting yourself, are you? When we ask questions like that, that closes the door, that makes it seem less open. And so ask your question, be direct. Again, ask us, reach out for help, but also when you're asking others. Next slide, please. This slide shows data. It came out in 2018. It's data from 2016, so it is somewhat dated. There's a lot of information here I'm not going to delve into in great detail, but I just wanted to share this with everyone to show there are suicides happening in Iowa. There are too many people, both in Iowa and nationally, who die by suicide. And this slide pulls together data from a bunch of different sources that shows it's not just one subgroup of our population. It's not just young people. It's not just white males. It can affect anyone. And when someone dies by suicide, it creates an impact on everyone around them. It doesn't even have to be someone who was real close to you. It may have been someone who worked in your office who you didn't talk to all that much, but you can have a response or reaction to that ultimately puts you at greater risk as well. And so, suicide has impacted almost all of us on this webinar today, and almost all Iowans in some way, shape, or form. Again, it's closer to you, probably more of an impact if you've lost more people to suicide. There's going to be some buildup of that effect, but it has impacted so many of us, and it is something that, despite COVID-19 and everything we're focusing on with the pandemic, it is an epidemic in our country, and something that we all can do something about. And hopefully you'll feel more comfortable doing that after our time together today. Next slide, please. I did see a comment just come through saying, when will more recent data be released? This is updated on an annual basis by an organization not associated with IDPH called the American Foundation for Suicide Prevention. But we have data up through 2018 that I use. 2019 data will be certified a little bit later. So we can slice and dice data in different ways that I'll talk about at the end of our presentation today. But I can tell you that when we look at from 2000 to 2018 across age groups, I think I have maybe 20 age groups, from 0 to 99, every one of those age groups has increased since 2000. It's not again, it's not just one age group that's spiking up. It's a pretty gradual and comprehensive increase across the ages, which to me just tells us we can't focus our resources in any one area and forget about others. Great question. Wanted to talk very briefly about risk factors and warning signs. Our next slide will have a URL where you can go and actually read and see what some of those risk factors and warning signs are. But risk factors tend to be more general, whereas warning signs are acute. So if someone is presenting warning signs, especially a multitude of warning signs, to me that means we need to intervene now. Risk factors can be present, they can be permanent or passing. If someone has lost their job, again, something particularly relevant right now, that is a risk factor for suicide. But when you get a new job, when things bounce back for you, that can kind of fade away. Whereas a more permanent risk factor is if you've had a previous suicide attempt, or you've lost someone in your family or your close circle to suicide. That may ebb and flow, but that's always going to be a risk factor for you throughout the rest of your life. Unfortunately, risk factors are common. Again, talking about suicide loss. If you're a suicide loss survivor, we've all felt that. If you're a Robin Williams fan, I'm a huge Robin Williams fan, Chester Benningfield, sorry. I'm not doing justice to his last name, the lead singer of Linkin Park. If you're a fan of those famous people, I didn't know either one of them, but I like their music and I like their comedy. That touches me in a way that I can't quantify or can't really account for. So again, it's way more common than we see. And again, with risk factors and warning signs, I call it a numbers game here because I don't know what else to say, but the more we have, the more at risk we are. And so if we can mitigate those risk factors, if we can address those warning signs in the immediate time, we can help keep people safe and connect them with resources. Next slide, please. Again, I referenced the website where you can go and this presents a whole bunch of different warning signs and risk factors and gives some descriptions and resources as well. And that is a hyperlink. So when you get the slide deck sent out, you can check it out. Otherwise, if you can read the small print, the URL is there. Again, it is from the American Foundation for Suicide Prevention, which is a wonderful overall resource, and would encourage people to visit there and see what might work for you in your situation, in your employment, your community, and everything along those lines. Next slide, please. I want to briefly acknowledge that language does matter when we're talking about suicide. I said earlier, it's okay to call it suicide, to say, are you thinking about killing yourself? Here are some other suggestions. Again, we want to show we care, we want to reach out to others, but if we can do it in a way that doesn't stigmatize or doesn't kind of, yeah, I'm asking, but I don't want you to say yes. If that matters. So instead of saying someone committed suicide, they died by suicide or died of suicide. A great example as it relates to COVID-19, for the longest time, since this all started, we're hearing about social distancing. And just this morning, heard on a national presentation, the speaker talking about mental health and suicide, was really advocating for it's not social distancing, it's physical distancing. We want people to stay apart physically, but we can still connect in so many ways. You can still talk to your neighbor across your fence. You can still talk to people when you're walking down the street, as long as you're maintaining that safe physical space. We can use FaceTime, we can use Zoom, we can email, we can send letters. There are still ways to be socially connected while physically distancing. And when we say social distancing, for people who that's their only thing that they're here for is, hey, you know what? I go to work, I see my coworkers. If I didn't have my coworkers to go see every day, or if I didn't get to talk to my neighbor, weekly when we go out to get the newspaper from the mailbox, I don't know if I would be here right now. How can we maintain, how can we keep those social connections up while keeping everyone safe and keeping that physical distance? So not necessarily related to, or not directly related to suicide prevention, but again, that language does matter. And these are some other examples of ways we can say it in ways we should try not to. This doesn't mean if you accidentally slip up because you grew up and you've heard for your entire life commit suicide, that's that's a cardinal sin, that you're horrible for saying that. No, it's just try to be more aware of the language we use. Mistakes do happen. We're all human. People will give you grace and give you acceptance, but just try to remember, okay, how might this impact the person that I'm talking to, or the other people that might hear what I'm saying and how I'm saying it. Next slide, please. And here are some examples of what you can do. I start with ask. And that shows the person that you're concerned about that you care. And if you're feeling suicidal, asking for help. Again, people who are experiencing suicidal ideations, asking is not an easy thing to do. And so it might need to rely on those of us around that individual to ask them, are you feeling suicidal? Are you doing okay? Is there anything I can do to help? Again, express your concern. Let them know why you're asking. Listen, just be there, be in the moment with them. And that, again, in today's time, that might be listening on the telephone or listening on a webinar, using Zoom or FaceTime or something like that. It might not be sitting at the kitchen table or celebrating Easter. It's going to look a little different, or may look a little different, but there's still ways to show that you are listening and that you are processing and that you are there in the moment. Again, there are more examples here. Some of these are going to be more challenging. Again, with COVID-19 and the situation we're in, it's going to be harder to find treatment and connect with resources. It's going to be harder to get crisis support and things like that. That we're using telehealth. We're trying to find other ways to still provide that support while keeping people safe. But it may look a little bit different, but that doesn't mean it's not there. So again, these are additional suggestions on what you can do, but most importantly, we can all ask. We don't have to be afraid. It's not, if someone says, yes, I am suicidal, it's not just on our shoulders, that there are resources out there. There are people who can help, who you can pass the torch to or share that load with. It can be a mental health professional. It can be calling Your Life Iowa or the National Suicide Prevention Lifeline or any of the other helplines that are out there. It may be a faith leader. It might be a trusted colleague that can provide additional support and resources. And so, reaching out to others so that it's not just you helping that individual can really lighten the load and keep that person safe. Next slide, please. This is a slide that has a whole bunch of different logos and names on it. I'm not going to talk about each one, but these are places where I would go. Places that I think are good resources, are places to get additional information. And so you'll have this slide. You can Google these names, things like that on your own, but do check them out. You can always reach out to IDPH. Email me and I can connect you if I can't help you directly. The three that are in kind of rectangular boxes, the Suicide Bereavement Support Groups, Iowa Suicide Prevention Planning Group, and the County Suicide Prevention Coalitions, you're not going to be able to find them if you Google that. But those are resources that we know are active in Iowa. Some counties have suicide prevention coalitions. Lori's going to talk about that in a bit more. But we also have suicide bereavement support groups. So if someone has lost someone in their life to suicide, these support groups are doing wonderful work in providing solace and support and a place, an outlet where you can go and talk to and hear from others who have lost someone close to suicide, because a loss to suicide is not the same. It's not the same as a loss to cancer or a traffic fatality or other forms of loss. And so the suicide bereavement support groups help fill that gap and provide supports. Unfortunately, we don't have one in every county in Iowa. I think we have approximately 20, at least that we are aware of at IDPH. And so there might not be some that are as close to you as we would like, but I'm certainly open to having discussions, seeing what we can do to help get more out there. And I'll talk later, if time permits, about the Iowa Suicide Prevention Planning Group. Next slide, please. And again, I talked a little bit earlier about suicide risk and protective factors. We gave you the website where you can find that information, but just did want to share this out one more time, that many of us have multiple risk factors for suicide, and it's around us. It happens that there's way more people dying by suicide than any of us would like to see. But that doesn't mean that we are all engaging in suicidal ideation, or that we have a plan, or that we've made attempts. And it's how do we mitigate those risk factors while enhancing those protective factors that are around us. And again, not to keep going back to COVID-19, but some of those protective factors are removing isolation, engaging with others, and that's so much harder right now. And so what can we do? What are those tools? What are those creative ways we can leverage technology and all of us having more time at home than we normally have to reconnect, or to connect with those that we are concerned about? It's just something that we are all kind of uncharted territory and doing the best we can, and I suspect we'll get much more information as we go on. I am going to talk at the end of the time today about additional resources that we have available through Iowa Department of Public Health, and some of the other initiatives more specifically that we are doing. But having said all of that, I don't want to take any more time away from Lori than I already have. And so without any further ado, I'd like to turn it over to Lori.
Thanks, Pat. One thing I didn't want to interrupt you while you were speaking. Can everybody hear me?
I can hear you.
Okay, super. I'm going to apologize in advance. My dog will bark here in the near future. He's very protective, and he's hearing voices he's not used to, so I apologize for that. The suicide bereavement group information, we could certainly send that to Claire so she can send it out to everybody. I can't see what questions are, so maybe that was a question that was posed, but we can certainly send that to her so she can include that with the information that you guys are getting.
Absolutely.
Great, thank you. We also had someone in the chat when Pat was sharing the slide with the suggested bullets around like asking and connecting people with resources. Somebody asked if they could share that on their social media, and so I said that we would try to find a few things maybe to send out when the resources go out. Maybe we could have like some infographics or some things that were already like formatted in a way that if folks wanted to share it with collaborators or share it on social media, it would be in a format that was easy for them to do that in. So we'll put our heads together on what would be the best fit, and we'll get those out to folks when we send the follow-up materials.
Okay. So first, I want to thank Pat and Claire for giving me this opportunity to share with all of you what the VA is doing around suicide prevention efforts. The VA is kind of like Willy Wonka's factory, we're that secret entity up on the hill that people don't necessarily know what we're doing or what we're not doing. And so this is an opportunity for me to share what we are doing, and then also how you all can incorporate what we're doing in your opportunities, or or share with us what you're doing, because obviously we're not doing everything 100% perfect. We have room for improvement, just like probably everybody else feels like they do. But this is just a great opportunity to collaborate on what everybody's doing in their suicide prevention efforts so that we can work together and save more people. I personally have it as my mission to try and reach out into all of my communities, what the VA has to offer and the resources that we can bring. I travel throughout my catchment area. I don't right now because I'm not allowed to, but I'm usually on the road 4 days out of 5, making sure that that's getting spread as far as I can within the catchment area. So always want to start out with some stats because, you know, why are we doing the work that we're doing? This is the data from 2017. The reason it's 2017 and not 2018 is because that's the most recent veteran data that we have. And so for comparison reasons, it just makes sense to use the national numbers for 2017 in addition to the veteran numbers. I can tell you from the CDC report from 2018 that in the United States, there were 48,344 suicides. That breaks down to about 132 a day. And they're estimating that for every one of those suicide deaths, 147 people are impacted. So just some numbers to kind of keep in mind that this is continuing to be, as Pat said, unfortunately an epidemic. And I try not to use that exaggerated language very often because he's right, language does matter. But you know, facts are facts. It is unfortunately an epidemic. So what you see here in this graph is the bottom lighter blue line are the veteran numbers, and then the higher blue line are national deaths. Our veterans, our military folks, we're kind of keeping a steady number there. We've only had an increase of 6.1% between 2005 and 2017 in comparison to the nation, which has had a 43.6% increase in suicides. That doesn't mean that we quit, that we stop doing all of the suicide prevention efforts that we're doing for our veterans and military, because we're not, because 20 a day is still too many. We're going to keep doing all the things that we've been doing, and I'm going to share those things with you in just a second. But we also have to come up with new and innovative ways, because we got to start getting that number to come down and not just staying steady. So when you look at these statistics, it shows that the veteran population is also, let me go back one. The veteran population is also coming down. Where are the disconnect, where there's more veteran suicides than there are some other categories, but we're also losing veterans just naturally because they are aging out of well, existence, unfortunately. This statistic just shows you a little bit as far as how many veterans we lose every day. When you look at the national numbers, in 2017, there was 124 Americans that died by suicide every day. And in 2017, there were 16.8 veterans that died by suicide every day. So my guess is right now, everybody's going, no, wait a minute, we're talking 20 a day. Why are you now telling me it's only 16? When we say 20 a day, we're not just talking about true veterans. We're talking about veterans, never federally activated guardsmen and reserves, and active duty members. We're talking about all folks that have any sort of military service. And when you add all of those numbers together, that's when we get the 20 a day. I put this slide on here because I wanted to show the conditions that people may be diagnosed with that are dying by suicide. So these are the folks that are already coming into the Veterans Hospital. They've been diagnosed and then they go on to die by suicide. These are the conditions that we're finding most prevalent. I know a lot of the folks on this call, I think, are in the substance misuse prevention world. And so I really found this one interesting because that dashed blue line at the top, those are folks that have been diagnosed with an opioid disorder. And the red line a little farther towards the bottom, those are the folks that may have a substance use disorder condition in addition to other mental health conditions, because we all know that there's a lot of comorbidity in mental health diagnosis. So I found this interesting. This does not necessarily mean that those people died by an overdose. They could have died by suicide by another means, but that they had this condition at the time of their death. So the graph that you have in front of you are suicide deaths by method for Iowa for just a few years, so 2013 through 2017. And the comparison here is between the general population and the veteran population. We usually, when I'm talking for the VA, we're talking about this as far as firearm deaths. And I don't know if I click, nope, it won't light up. So usually when I click on this at home, it shows the actual percentage, but you can see there in 2017 that blue category, that's firearm suicides. And for the veteran population, it is the higher percentage. Under the general population, poisoning, which would be what an overdose would be, is that lighter blue part up here at the top. And then suffocation is in the middle. In comparison, these are the national statistics. And this is broken down a little further between male and female veterans, as well as the general population and veterans specifically. Again, usually when I'm talking about this slide, I'm referencing the firearm deaths, because female veterans are more likely to use a firearm than their counterpart in the civilian world. But you can also see the numbers, how they break down for other means. Any questions about any of that? Okay.
So we have someone that's asking what's being referenced as a method of suicide when it's listed as other. So can you give an example of what would fall under that other category, please?
Yes, let's see. Cutting. If someone cut themselves to the degree that they were able to end their life. Single person car accidents sometimes are considered suicides. Drownings or jumping from a height, those kind of things would fall into the other category. I don't know why my brain froze for a second there, but
and that's something we could always follow up with as well, if that's helpful.
Okay. Yeah, I mean, so when you look at poisoning, this is a way that so obviously overdoses on medications or alcohol or drugs, but also folks that would truly poison themselves, antifreeze or something like that. Suffocation is where hangings fall into, as well as some other more graphic means that I don't think I'll get into in this. But other is kind of that catch-all category, unfortunately, for anything that doesn't fall into those three categories. So
Lori, someone's also asking if you have any data related to combat versus non-combat veterans.
No, not necessarily. That's a little harder to tease out, especially if we're talking about specifically Iowa numbers, because the numbers that you have on here are national numbers, and for Iowa in 2017, we lost 71 veterans or service members to suicide. That's the number for Iowa. When you get anything below that, then it gets a little bit too close to where you could figure out who you're talking about. And we would never want to breach anybody's confidentiality by doing that sort of digging. So I don't necessarily have where I can easily reach it, combat versus non-combat. Sorry.
Well, and I think it might be even hard to define those two groups. Like, is it just by, did they serve overseas or things like that? And so how you categorize could prove problematic in a situation like that too.
One thing that I can speak to as far as risk factors, uh, something that we're noticing, well, okay, if we take the 20 veterans and service members that we lose every day, 6 are involved in VA care, 1 is an active duty member, 4 are guardsmen or reserves, and then 9 are true veterans that for whatever reason aren't coming into the VA. There are multitudes of reasons why they aren't. Some it's eligibility, some, I mean, there's lots of reasons. But when you look at that 1 active duty versus 4 guardsmen or reserves, one of the risk factors that we're really trying to pay attention to is when you come back from deployment, if you're an active duty member, you stay with your band of brothers. You are continuing to live your life pretty similar to how you were while you were in that combat zone. You're with the same people, you're doing the same stuff, there's more debriefing, that kind of thing. If you're with the Guard or Reserve, you come back from a deployment, you potentially go home and you're no longer with all of those people that have just been through what you've been through. So you lose that support system, you lose that brotherhood. You also may be going back to maybe not having a job or trying to get back into your family system where you've been gone for 6 months, a year. It's hard to make that transition. And so that transition time is a high risk time for our folks when they're coming back to deployment, especially for folks in the Guard or Reserve. Did that make sense?
Yes, thank you. And I know, Lori, that you don't have the chat up on your end. So Drew had said he was thinking particularly to based on service medals, and Pat had responded that we can do a little bit of digging also and see if there's something particular that we can tease out and share as follow up to the webinar. So so thanks everybody for those that shared questions. And if you want to keep the questions coming in the chat, we'll let Lori I think continue on from here, and then there'll be we'll keep collecting those. So feel like you can keep adding them in the chat.
Okay, I can reference just one other statistic, and then we'll move on to the next part of what I was going to talk about. When we look at all of our veterans, we have the highest rate of suicide for male veterans ages 18 to 34. So that would be the folks that have been in the most recent wars, but we lose more veterans 55 and older. So our Vietnam era guys are the ones that we're losing more of. Part of that is because we have more of them. There are more veterans, especially in Iowa, that fall into that age group than our younger folks. But that's a statistic that maybe speaks a little bit to what your question is as far as those that have seen combat versus those that have not. So, so what are we doing about it? What is the VA doing to serve those that have served? Suicide prevention efforts have been in place for a long time at the VA. And the next few slides, I'm just going to share what the initiatives are that have been in place since 2017 when this report came out, and where we're at on them, and then how we can kind of collaborate in the general public with all of those things that we're already doing, that we maybe have the resources to bring those to our communities. So the first one, of course, we have to talk about the Veteran Crisis Line. And the thing about the Veteran Crisis Line that I want to kind of remind everybody is that number, that 1-800-273-8255, that is for everybody. That is the national crisis line. Anybody on this call, anybody in the United States can call that number if they're in crisis. It doesn't have to be just when you're feeling suicidal. Anybody having a bad day can call that number. If they aren't a veteran or military person and they don't press 1, it rolls into 2 local call centers. They're trying to have all of the calls in Iowa answered by these 2 different call centers that are in Iowa. That doesn't always happen. Sometimes it gets rolled over into somebody that's a little bit farther away just because of necessity, but they are trying to keep it local so that people are able to give local resources. The two that answer that call are Foundation 2 and Community. I'm not sure how they say that exactly, so you know how it, because it's COMM, big letters, and then Unity. So if you guys are on the phone, please correct me as to how you say that. But they're the folks that get the majority of the Iowa calls that aren't veteran or military. For the press 1 part, if you are a veteran or a military person, or the family member of a veteran or military person, or a provider that is working with that veteran and you're not sure what to do with them, please, when you call that 1-800-273-825, press 1 so that you get the Veteran Crisis Line. The reason for that, I want to talk about some improvement that's happened with the Veteran Crisis Line. And I'm going to skip up a slide so you guys can see this graph because I really like the numbers on it. But the crisis line has improved the answering of the crisis line calls from 70% in 2017 to 99.96% of the calls are answered within 8 seconds. They're almost better than 911. Not saying you should call them over 911. Always call 911 first because we want to make sure that the people are getting immediate help, but as far as their timeliness of answering a call. So that's the first initiative. We're going to expand the crisis line. They answer about 3,000 calls a day. They are in the process of going to a 3-digit number, which will make it easier for everybody, but they want to make sure that the infrastructure is in place to stand up under all those calls. From a conversation with Claire and Pat that I had the other day, I did some digging, and during the COVID-19 crisis, nationally, crisis line calls have gone up about 20%. We are not seeing that locally as far as the veteran part of the crisis line, that the calls are going up exponentially like that. What we are seeing is the calls that we're getting are more about some frustration with services because so much is closed right now or only accessible over the computer or the phone. And so some of the veterans are frustrated with getting hold of the providers that they need to get hold of. And so we're getting a lot of calls under that. And we're also having a number of calls currently that have to do with increased alcohol consumption. And my suspicion is that's because they're not able to use their usual coping mechanisms due to the social distancing, which unfortunately is not the right wording for it, but that's what we're calling it. And so we are seeing an increase in those two areas, but not necessarily the jump in calls like national. So the second initiative there, that research and innovation, this just is, the VA is able to test different evidence-based practices as they roll out. And then when we find out the ones that are more effective, we can roll that out to our community partners. That third one there, community partnerships, you'll see that that's highlighted. That's because I'm going to talk about that a whole lot more in just a little bit, because that is 100% the part of my job that I do there at the VA. And I wrote myself a bunch of notes. I'm trying to figure out what all I wanted to talk about under that. Originally, this started out as just trying to raise awareness over the VA suicide prevention resources and educating people on what they can do to help veterans in their community. Along the same line is 24 communities participated in the Mayor's Challenge, and the Mayor's Challenge then has grown into actually a Governor's Challenge. And right now, Iowa has not been chosen as one of the states to participate in the Governor's Challenge. That doesn't mean that we won't be in maybe the third and fourth round, but the first couple of rounds we haven't been chosen. But what they have done is they've created a group that's working on infrastructure for suicide prevention for the state. Pat can certainly speak to that better than I can, or I don't know if Destiny's on the call. She could probably even better. But we're working together to try and come up with a a way for us all to be able to work together in a more consistent manner, so that all of the great work that people are already doing, we can just be able to show that a little bit easier. Pat, maybe when you talk again, you can reference that.
Definitely.
So under clinical partnerships, we are partnering with community-based mental health providers to make sure that our veterans can be served in their communities. You guys probably remember a few years back, there was a program that rolled out for veterans called the Choice Program. It was misnamed. There was not a lot of choice for anybody in that program, but it no longer exists, and we're now under what we reference as the Mission Act. It works kind of the same, where providers in the community can contract with a third party to provide services for veterans right there in the community. Right now, obviously, there is a hold on that. We can't send people out into the community with the restrictions that are in place because of the virus. But this is a way to expand services for veterans and military, where they aren't necessarily having to drive 3 hours to their closest VA. They can be served right there in the community. And it's a way of partnering between the VA system and those community partners. If anybody on the call, their organization wants to be one of those providers, reach out to me and I will get you the contact information so that they can get listed as one of the contract providers. So outreach, that's the next initiative. It's also highlighted because I'm going to talk about that again a lot more in just a minute. For the entire existence of the suicide prevention protocol at the VA, there have been suicide prevention coordinators that are performing outreach in their communities. There are about 400 suicide prevention coordinators throughout the country. And what we have done in the last couple of years is expanded that a lot. And I'll talk about that in just a second. The next initiative that you see there, the mental health SAIL expansion, this is probably not really very important to most of the people on this call. These are the things that we measure, the metrics that we have to uphold. Everybody on the call probably has those measures and metrics in their own organizations that they have to answer to. This is our way of showing leadership that we are reaching the people that we are setting out to reach. Some of the things that we monitor at the VA, just for reference, if we have a veteran that has had a suicide attempt or strong gestures towards an attempt, we will put what we call a high-risk flag on their record. And this is not supposed to be a punitive thing for the veteran. It is so that all of the providers that are working with that veteran know that they are at high risk, and we need to be making sure that we are having more contact with them. And if they miss appointments, so we're following up with that, different levels of care. There is a standard to that as far as how often we reach out to them. Usually you have a flag on your record for 3 months, and then we review it to see if it needs to be continued, or it can be discontinued if the person's doing well. We also monitor all of our discharges from vetted units. So be that the psychiatry unit, the just general medical unit, or the domiciliary. The VA does have a residential program for PTSD and substance abuse, general mental health, and then our homeless work ready program. And any of the folks that are discharging from that, we monitor for a number of weeks following their discharge. The reason being, we have found through lots of study that people are at their highest risk 30 days after a discharge from a hospitalization. And so we want to make sure that we're reaching out many, many times during those 30 days and offering the services that might enhance their situation. We also have a program through the VA that we call ReachVet. It's an acronym, and I can't remember what all of the letters stand for, but we like our acronyms at the VA. And what it is it's an algorithm that pulls up veterans within the VA system that may be at risk for premature death, not necessarily suicide, but that their lives may end earlier than would be expected if intervention didn't occur. And so we follow those folks closer than your general population. to make sure that they're engaging in services, but also that they're being offered the services that would be relevant in their situation. That next initiative, that primary care mental health integration, this is our innovation to try and have more same-day access. We don't actually have urgent care at the VA hospital. That's part of why the Mission Act is so important, because we can send people out to urgent care in the community now. But we are able to, through primary care mental health integration, if someone is in primary care and having a mental health issue, they can see a psychiatrist or psychologist, hopefully same day, to address those issues and get them involved in care. In 2018 alone, the VA provided over 1.2 million clinical encounters for over 400,000 patients. So that's a pretty good number. As we all know, a lot of mental health service is provided during primary care appointments, and this is just a way of increasing the collaboration and getting people served quicker. Universal screening. In 2018, the VA implemented a 3-step risk assessment screening protocol for all veterans. What it is at every appointment, a veteran will be asked the PHQ-2 questions. I'm sure you guys are all familiar with it. You've probably been asked yourself if you've gone to a doctor's appointment. They are the, have you lost interest in things you like to enjoy? And the second one is, have you felt down, depressed, or hopeless in the last 2 weeks? If you answer yes to those, then we go on and we ask question number 9 on the PHQ-9, which is, are you having thoughts of harming yourself or ending your life? If that is positive, then the next step on that is we complete a full Columbia assessment for that veteran. And if that is positive, then it goes on to a full comprehensive screening that has to be done by an LIP, licensed independent practitioner. So someone that can either prescribe or diagnose. And depending on how that turns out, would they be hospitalized, or would we be sending them home with services, or what would happen? So more than 2.8 million veterans have received the standardized risk screening since October 1st of 2018. So that's a lot of folks. The neat thing that I'm seeing as I'm traveling around my catchment area is there is a lot of standardized risk assessment happening in our county hospitals and our primary care offices across the state. And while the opportunity here is for us all to work together so that we're all speaking the same language. If we're screening everybody in the same manner, then we're hopefully going to be able to just speak to that a little bit clearer. Mental health treatment coordinator is the person that we assign to the veterans for so that they have a person to reach out to. It's easier than trying to go through the phone tree to get into your provider. This is usually a nurse or a therapist. That is also the person for you guys in the community to reach out to if you're concerned about a veteran. These last couple, care related to the military sexual trauma. I wanted to have that on here just so that you guys know that this is actually a free resource for any service member, regardless of discharge from the military or financial means. They can come to the VA and have treatment, physical or mental health, for military sexual trauma. We don't make them prove it. They just have to say this has happened to them, and we can get them involved in care. And then the last one on their women's health, mental health. We have found that right now, the rate of suicide is 2.2 times higher among female veterans than their non-veteran counterpart in the civilian world. And so they have created a lot of programs specifically for our female veterans. Okay, that was a lot of information there. Everybody still with me?
Yes.
Yes, we're here.
Super. Okay.
And you,
All right.
And so, and this, Lori, this is great. And I feel like it's going to be a good fit that we've got, just so folks are kind of tracking, we've got about 10 more minutes for Lori's content. And then we're going to have Pat talk a little bit more specifically about some resources from the department. And then we're going to leave some time at the end for some additional questions. So yeah, we're here. Carry on, Lori.
Okay, so because of those initiatives around community partnership and outreach, Vision 23, which is the Midwest region, and I'll show you a map in just one second, that shows what that area is. They created my position, which is the Outreach Education Specialist. They're changing our title. I'll talk about that in a second. Because we are taking a public health approach to suicide prevention, what we're trying to do is reach as many people in the community that might have interaction with veterans to try and bring down that suicide. So that's the catchment area, or that's the region, I'm sorry. So what did we do? Well, we started out just doing typical outreach and awareness. We went anywhere that people would let us go and have a table. There is a stigma around the VA, and so sometimes it's hard to get invited places, and so we would literally go anywhere that we were allowed. We also do a lot of education. This list of trainings that's on here are all the trainings that I can offer to anybody that we partner with, any community organization or whatever. And most of these I can offer free of cost. Operation SAVE is basic risk assessment training. It does talk to, how do we work with the veterans, but it's all translatable information that you can use in any population group. So in January of 2019, the Office of Mental Health and Suicide Prevention came to us and said, we're going to hook you up with the University of Pittsburgh PERU program, which stands for the Program Evaluation and Research Unit. They were already building coalitions in Pennsylvania around opioid overdose awareness and prevention. And they were using a structured system for coalition building that they were now bringing to the Midwest that we are going to use around suicide prevention. This next couple of slides are just about how public health works. Most of the people on the call may already know this kind of stuff, but you use the public health approach because you can be quick and effective, and you can cover a broad number of people all at the same time. You want it to be structured. You want to have a diverse membership in your coalition so that you can reach farther with whatever it is you're trying to serve. Suicide prevention specifically, again, it's the same kind of thing. You want to have a systematic method. You want to have everybody be on the same page. You want to have all the people at the table that you want to be there. So this is probably very familiar for everybody, but this is the structure of the coalitions that we are able to either help start or enhance ones that already exist. When we talk about assessment, we had the opportunity in April of 2019 to send out a survey to all of the folks that we could. A lot of people on this call may have gotten that survey from someone. And what we were looking for was what already exists in those communities. What are people aware of as far as suicide prevention initiatives or programs? And we also sent out a survey about stigma. We kept that stigma survey specifically to suicide versus mental health and suicide because we really wanted to see where people's opinion was just around folks that may have attempted suicide in the past or had those ideas. So when you look at these numbers, it's kind of sad. So of 279 people, only 23 were aware that the VA had any sort of suicide prevention initiatives. And only 21 of those people knew about NAMI, and then all the way down the line here. These numbers are super frustrating for me because I was literally in front of them talking about suicide prevention and providing these surveys, and still only 23 out of 279 people knew that we existed. So that speaks to that, I guess. This one, we also asked, who do you think are the high risk groups? And so probably no surprises here. What floats to the top, teens being the highest one, but then you do see on there folks with substance use disorders being mentioned a number of times. And so these were, this gave us a good baseline as far as like where we should be going to create these coalitions and what we could do about that. So if we're, this is our pilot project. On the left there, you see the initiatives that we're trying to complete. I work as kind of a technical assistant for the coalitions that I work with the referencing from my Peru TA, who helps me with all of my resources. For a coalition to be successful, you want to have the right people, but also people that are motivated towards change. And then you'll implement your initiatives. And hopefully, if all of these things work, we're going to see those suicide numbers come down. When you're talking about building capacity, you want to have folks at the table. This is just a breakdown of maybe some categories that would be good to have involved with any sort of coalition, be it substance abuse prevention or suicide prevention, or ideally, those two organizations working together towards a common goal. The initiatives that we started with our pilot goal, as far as the planning part, we of course use the public health approach and break it down between universal, selective, and indicated. These are the goals that we have already targeted. Much of the work has already been done for all of these goals. I like to look at them as kind of like training wheel goals. So you're working with a coalition that's already in existence. If they were wanting to work on any of the goals that are present in our initiatives, all of the research and all of the data has already been collected for all of these goals. And so you can kind of hit the ground running where you aren't having to figure out what direction you're going to go in. And so we can kind of work through these goals a little quicker and then get on to whatever the community is wanting to work on. What I found through my travels is there's a lot of great work going on already in a lot of our communities, but not everybody knows about it. You saw that from my awareness survey. People don't know that great work is happening in their community. It's also hard to report that to your community or to the leadership in your community without some sort of structure. So this is all a way to pull all of that work together where people would be able to represent up through their chains of command what they are already doing. I personally am working with 5 different counties on coalitions specifically for suicide prevention. 2 that were able to be initiated through this pilot program. One of those counties is already on the implementation stage of that structure. They are already doing the work and getting out there and doing all of the things they need to do. And the other one that started from the ground up, they have just done their strategic planning. They have just chosen their goals. And still this month, because we're doing everything over Zoom, they're going to be able to start figuring out how they're going to implement those goals. This is Iowa and how the VA is broken down into catchment areas. I'm the pink part there in the middle. The next few slides are just the contact information for all of you folks as far as if you're in any of the counties that are listed in these soon-to-be slides. That's the person you should reach out to get involved in this coalition work. This is me. The counties that I'm already working in are Polk, Ringgold, Decatur, Greene, and Buena Vista counties. Those are my facilities. Katie is over out of the Iowa City VA, and these are her counties. last time I checked, I know she's involved with 9 coalitions. I don't know exactly which counties that they fall into. Some of the folks on the call probably know Katie and know that answer. I'm just not sure which counties they're in. Gina is out of Nebraska, Western Iowa, so she has counties in Nebraska, but she also has a handful of counties in Iowa. She has helped to start a 5-county coalition over there, and the counties that are represented in that are the first, well, it's Monona, Crawford, Harrison, Shelby, and Potawatomi, if I remember correctly. John is out of Sioux Falls. He's been focusing a lot more in South Dakota, obviously, because that's more of his catchment area. But I know he's involved in the Tri-State Coalition. And then he also is talking to some folks up there in that northwest corner about starting a coalition in that corner of Iowa. Those are their facilities. And then it's going to go to Pat. Sorry, I totally just sped up on you on the end there, but I wanted to get it all in like 10 minutes I have left.
Lori, I am seriously impressed. That was so much information, and it is literally 2:10 on the dot. So impressive to share such a great amount of information. So if folks want to have any questions that you have, I think what we'll do is have you add them in the chat. Now, we're going to have Pat just do a brief additional piece here around some specific things that the department has as far as resources. And then we're going to leave 10 minutes at the end to answer the questions in the chat. And I will also unmute folks if you have a specific question that you would like to ask the presenters at that time. So Pat, let's virtually hand it over to you to kind of wrap up the content here.
Thank you, Claire, and thank you, Lori, for the wonderful information and the presentation you shared. I appreciate both of you for being here today and with us. Want to talk about some of the general suicide prevention efforts that we're doing through the Department of Public Health. Early on, I shared some data, and we had a great question come in about when are more recent data coming out, and I gave a bit of a response there. But we have access to data, surprise, surprise, but some of it we don't publish, or some of it we don't have the resources to mine into as much as we would like. So if you are at a county level, at a community level, at a regional level, and you are interested in having data for your area, for presentations you're doing, or to aid in grant applications or anything like that, please feel free to email me. I did put my email in earlier in the chat, and I believe it is on the slide deck as well. But I will assist in seeing what we might be able to give you and getting it to you with explanation and support as needed. So please do reach out. Most of the data we have access to as it relates to suicide comes from death certificates. So it does get reported from medical examiners from across the state. So if you have a connection with your local medical examiner's office, you're going to get more real-time data than if you wait and come through us, but not everyone has those connections, and not all medical examiners have a lot of extra time to support and do things like that. So please feel free to reach out for questions as it relates to data. We do have other data as well. There's the Iowa Youth Survey, which is a survey done with youth. We ask questions about suicidality on that survey. There's the BRFIS Behavioral Risk Factor Surveillance Survey, which is a survey done of adults. Also has questions on suicide, and we have hospitalization data and other data as well. So if you have specific data needs, please do feel free to email me. I'll probably come back to you with some questions to make sure I'm understanding the request and can frame it properly, and then we'll see what we can do to get you that information. We also try to support community coalitions. Lori's doing a lot of wonderful work, and there are some coalitions that have been around before I was around. So it's, how do I connect with them? What support can we offer you? Are there resources? Is it connecting with other coalitions? Not to come in and say, hey, you should be doing it this way, or hey, we'd like it if you worked on this effort specifically. So how can we support that important work? Because a lot of change as it relates to suicide prevention does come from that local, that community level. And so if we can support your group, your organization, whether it's a formal coalition or it's a family group who's trying to mobilize in response to an immediate loss, we're here to help. Maybe that's just listening. Maybe it's just coming to meetings once in a while. But again, try to tailor that to meet the needs of those individual organizations. I also talked earlier on about the Iowa Suicide Prevention Planning Group. This is a statewide group. We have about 30 members of people, some from state organizations, some from community coalitions, some who just want to make a difference. And it's really just a time for us to connect and share resources. Hey, what's going on in your world? Is there something that you've learned, or a new resource, or the new data that you've seen that you can share with us that can help inform our work? So it's really just a way to try to bring people together, again, from across the state, to further enhance the suicide prevention efforts that we're all interested and invested in. If you're interested in that group, want to learn a little bit more, please reach out to me as well. It's not a closed group. We welcome others, and we do value those with lived experience. It's not something we ask, but if you are a loss survivor or an attempt survivor and are comfortable talking about your experiences or providing that additional insight that you have to inform our processes, we're always welcome to that as well. As part of that Iowa Suicide Prevention Planning Group, or as a subset, and Lori mentioned this, we've convened all states, I believe, and territories and tribes were invited to take part in this process that a national resource is leading, a small group, a community of practice, to look at state or jurisdictional infrastructure. And so we're going through that process now. I think there's 6 of us on that group to try to see what we can do to better enhance, utilize, develop the state infrastructure so we can do better at suicide prevention in Iowa. We're early on in that step. Obviously, there's financial and personnel and time resources that do play a role in that, but trying to do with what we have, how can we be most effective? How can we get the biggest bang for our buck? And so that group, again, is a subset of that Iowa Suicide Prevention Planning Group, but is really trying to help us at IDPH and the state government as a whole do what we can with what we've got. And finally, Your Life Iowa, if you want to move to the next slide, we have a kind of a picture of that resource. This is a service that's available to all Iowans. It's very similar to the National Suicide Prevention Lifeline. One's not better than the other. There are other resources as well. This is the one that we've invested in. You can call, you can do online chat, you can text. Services are available 24/7, 365. Those are free and confidential. It started off as it was really a suicide prevention and anti-bullying resource. And over the last couple of years, we've expanded it. So now you kind of see the orange bars across the top, resources on substance use and abuse, problem gambling, mental health in general. So trying to bring together a lot of public health issues that could be correlated or co-occurring, where people can come and get resources on any or all of those. And I like to highlight that this isn't just for someone who's hurting or struggling themselves, because it is hard to reach out when you're in a deep, dark place. I don't want to talk about it, or, you know what, this is my cross to bear, I'm not going to share it with anyone else. Whatever reason, it's hard to reach out. So I like to put the pressure on everyone else that we can call out, we can reach out. You know, I'm concerned about my significant other. I'm concerned about my kid, my coworker, my neighbor, someone who goes to my faith organization, or who helps coach my kid's ball team. I'm concerned about them, but I don't know what to do. I don't know what resources we have in our community. Call Your Life Iowa. They will help. They will practice having that conversation to make you feel more comfortable, to help you know that you're not alone. As I said earlier on, this isn't a Pat has to fix it. Pat has to help his neighbor that he's concerned about. No, Pat can help have that conversation with that neighbor, know that he cares. But Pat and his community need to be there for that neighbor. And so Your Life Iowa can help make those connections and empower you, make you feel more comfortable to be that support, to be that first person, maybe that first person who reaches out his or her hand to offer that support to their person that they're concerned about. What we don't have on the slide is how to get to the URL, and it's simply yourlifeiowa.org. So YOUR lifeiowa.org. Again, a wealth of information, call, text, online chat, or you can just go and see some of the resources that are there. Next slide, please. What I've talked about so far are general things that IDPH is doing for suicide prevention. This is a specific project that we have that's called the Zero Suicide Iowa. Real creative. We put Iowa at the end, but it's really implementing the Zero Suicide Initiative. And I don't know how to describe this in 30 seconds, so bear with me. But Zero Suicide is really an organizational aspirational goal. We don't want to have anyone who comes into our organization die by suicide. It's originally researched in large hospital settings, and it's really appropriate for behavioral health settings. So substance use disorder treatment providers, mental health treatment providers, obviously hospitals. And it's really an internal review of all of our processes, how we greet people, how we navigate them through. Do we hand them off? Do we walk them to their next appointment, or do we say, hey, go down the hall and turn left and then turn right and then you're in the third room? How long are people waiting in our waiting rooms or in our exam rooms? What kind of ongoing supports do we offer them? All of those things. Really just, again, looking at all of those places where someone can fall through the cracks, or someone who might be at risk for suicide might get turned off, might get pushed away, might feel not welcomed, and what can we do differently? And so we are working with the safety net, the 20 substance use disorder treatment providers who are part of our safety net here in Iowa, to implement the Zero Suicide Plan, or implement the project, and trying to see how we can diffuse that out into other organizations who may be appropriate for that. At the same time, connecting with the community, encouraging those providers to connect with the community and providing additional resources and training to staff, and again, their broader communities, because this isn't something that just one group, one organization, one person can fix. We can all play a role in that fix, but it can't just be one area that is bearing that load, because it's not going to work. When we see people of all ages, of all creeds, of all sexes and races and ethnicities dying by suicide from all walks of life, we can't just expect one area to bear that load. And so really working with, again, those providers, but our communities, offering more trainings, raising awareness, getting the word out of what resources are there and what we can do, is really a big part of that project. And I threw on the COVID-19 impact. As with probably most of everyone else's worlds, things have changed quite a bit, and any in-person trainings and things like that are on hold right now. And so some of the things we had planned, we've had to pump the brakes on, and we're trying to see, okay, what are going to be the long-term impacts of that, both for Zero Suicide Iowa and our suicide prevention efforts in general, and that is very, very much up in the air. I can say that, again, with social isolation, with the downturn in the economy, with people losing their jobs and being unsure of how they're going to get their needs met, not just next month, but this weekend, the risk for suicide is great. And so if you have the ability to reach out to others via text, phone calls, FaceTime, waving from your window to them as they're walking by in the street, please do so. That if they're at risk, this could be a really difficult and challenging time for them, and we all need to do what we can to be there for one another while also taking care of ourselves. Next slide, please. I thought that was it. So that's all I've got. Claire, I don't know if you want to take over and MC for the remaining time together.
Sure, I'd be happy to. Thanks, Pat. And thanks again. I just really want to thank both Pat and Lori. We also, I think some of you were aware, we had a webinar that had already been planned, and with things just kind of changing and all of that, we decided to move this up. This was originally going to be our May webinar. And so I really especially appreciate Pat and Lori really being willing on short notice to jump in and pull this all together. And this was great information. So thank you so much. So real quick, I just want to say, and then we're going to have a few minutes and I'm going to unmute folks for questions. Don't navigate away yet, but at the end of the webinar, if you have a minute to just real quick navigate to this link and provide your feedback, we would really appreciate that. I use that information to plan for future webinars. I share it back with the prevention team, so it's definitely all read and useful. I also want to remind folks that after the presentation, I will make sure by email that you get a copy of the presentation, a link to the recording, anything additional that we talked about. I know we talked about trying to provide maybe some, do a little additional digging around veterans, as well as maybe some resources that were in a format that would make it easy to post on social media. Also, I will send your attendance and your CEU certificate. I didn't need everyone to let me know you were here. It's actually really easy to pull that out of Zoom if you registered, for me to see who registered and who participated. But if you joined from a shared computer, if you will email me or type it now in the chat, just to make sure I have your name and email to follow up with you. Otherwise, no need to do anything on your end. As long as you used the link that you got when you registered, I will know that you were here. So let me, I'm going to give you all the magical ability to unmute yourselves. So you should now be able to unmute, and if you have a question, feel free to unmute and ask it, or if you have any additional questions in the, you're welcome to still share them in the chat. We've got about 5 minutes left, but we potentially could also stay on for a couple of extra moments as well.
We did have one question come in about an article that can be used
yes, thank
about
you.
Your Life Iowa. I did attempt to respond, but I don't think I did a very good job of that. On the Your Life Iowa website, there is a spot for resources where you can pull down billboards and business cards and things that you can print off. That's not an article describing what Your Life Iowa is or can do. And so I will see if we have one, or if we have a good example that someone else has shared with us that they've put out, and we will include that information. Again, it would be recommendation. You can certainly tailor it to your community's needs, or maybe your newspaper has a number of character specification that you need to work within, but we will provide what we can to aid with that.
Thanks, Pat. Anyone else just have any questions, comments? Wow, Chris, that's great. Chris says her paper lets her do articles 1 per week. That's clearly you have cultivated a great relationship with your local media. That's awesome. I'll give just a minute. I've often been accused of I do not do well in webinars with like the silence. So I've been reminded sometimes that folks need time to think and to process. So I do want to just kind of like keep this space for one more minute here. If you want to unmute and ask a question, if you want to share something in the chat, please feel free. I will post the, actually, Lori, if you want to, you can advance the slide one more just to where the survey is, but you can't click on the slide itself. So I'm going to go ahead and post the link one more time in the chat for everyone, that we would absolutely appreciate your feedback. And sometimes the easiest way to do it is just real quick right at the end of the webinar to click on it. It should just take a couple minutes. Pat is sharing his email address again, and I can actually put mine in there as well. I can't type and talk at the same time. Yeah, that's it. Okay. Any other questions? Hopefully, if there's no more questions, that means we can edit out this whole very awkward last minute and a half of the recording. All right. Well, I just want to thank everybody for being here. Again, I want to thank Pat and Lori. I also actually want to give a shout out to Julie Hibben, who was my fabulous tech person in the background for all of this, helping us manage having so many folks join the webinar, which was great. Just a reminder that we do these the first Friday of every month, and I will be sending folks, if you registered or if I now have your email, we will add you to our list, and I will be sending folks out information on our newly rescheduled topic for May, as well as other topics that are coming up. So thank you everybody so much. Have a great weekend. Take care. Be well.